everyone. Welcome to Smart and Strategic Collaboration Services for EHV Recipients. I'm Mindy Mitchell from the National Alliance to End Homelessness, joined by my colleagues Mia Bryant and Moshier McDivitt. And we're really happy to have Dr. Marcella Maguire from CSH here to talk a lot more about something that we've been hearing from everyone across all the communities in the country, wanting to make sure that we get services interventions right with these awesome new EHV vouchers that have come from Congress. So we'll go ahead and get started. Just some housekeeping here. Everyone is muted. The webinar is being recorded, and the recording and the slides will be made available to all registrants within 24 hours of the webinar. So don't worry, you guys will get access to all of this information. In the meantime, please join the chat. Kay is our mistress of ceremonies there in the chat and in the Q&A, and we're really thankful to have her on the webinar today. Mia and I are going to talk to you for just a little bit about some considerations as we're thinking about how to roll out EHVs and services. And then Marcella, of course, is going to have a lot of really great information about possibilities for funding services with EHVs and building partnerships. So let's go ahead and get started. First, just kind of a level setting here, as we have shared in some of the previous webinars that we've done about all of these new federal fundings. This is a big time for this field. If communities can manage to use these EHV funds strategically, literally tens of thousands of people experiencing homelessness can be housed. So for the first time, we can achieve a really significant reduction in the homeless population and even end it in some communities. But to do so, we have to start with a set of values that will guide the strategic use of any of these funds, EHVs, and everything else. So just want to retouch on those really quickly before we get started. Communities should be using these funds to the maximum extent possible to reduce the number of people currently experiencing literal homelessness. Do not use these funds to serve people use these funds to serve people who have the highest needs, because they are most in need, but also because this has a really big impact on your homelessness system. It influences these folks remaining homeless longer, and they're usually the folks who are homeless the longest in our systems. It impacts the flow into the homeless system, and it reduces the number of unsheltered homelessness. Also, use these funds to reduce racial disproportionality and disparities, because the homelessness system can reduce those disparities that are coming in from other systems, but it can also continue to perpetuate them. So communities have the potential to use their data in a way that furthers racial equity by applying that information and analysis to the use of EHVs. Of course, partnerships are going to be key to the successful implementation of EHVs. All of these unprecedented funding opportunities we're seeing, not just EHVs, but especially in EHV, that partnership is built into it. Whether you currently have a strong relationship between your COC and your PHA and all of those other entities, things are happening fast. Roles are probably going to be changing. Clarity is going to be needed. MOUs got to get out like in 2 days, 3 days, right? So it's critical that you guys value these partnerships from the get-go, and that you're developing their structure in a way that's going to ensure more successful implementation now and down the road when more funds come along. Do act with urgency. These funds are for a crisis. Congress wants to see them spent quickly, and they should be spent quickly. People are literally dying on the streets, suffering in shelters, and they need help now, and that help is available. So some important considerations for mapping out your EHV strategy. Being smart and strategic, when we talk about that, we're really talking about reducing homelessness. And that begins with understanding that even with this vastly increased funding, some communities may not be able to house everyone currently experiencing literal homelessness, but you can really make a dent in it. So you have to be thinking about who's going to be housed. That has to go beyond just eligibility and what might be the easiest for you to do administratively. It may look different than what your community is currently focused on, and you have to be willing to kind of shift on that. as a community, your thinking should be laser focused on this historic opportunity to really, really bring down the numbers of people experiencing homelessness. This opportunity, also specifically the one that's brought to us by EHVs, gives us an opportunity for further strengthening that relationship between COCs and PHAs. In many cases, for a lot of you in your communities, this will be creating a brand new relationship between these two entities. Even though both are required statutorily to partner with each other, we'll leave that aside because what's in statute often is not what happens in reality on the ground level. But when you have these successful partnerships, you can really increase the capacity for moving the needle on homelessness. You have an opportunity to create and witness what a really well-resourced and meaningful COC-PHA partnership looks like and the impact that it can have. And knowing that those partnerships have the potential for a long-term impact, like actually maintaining functional zero on homelessness for all folks, not just vets, is really exciting for us. So again, hearkening back to some previous webinars that we did, I need us all to take a page out of the awesome Nichelle Carver's presentation from a few weeks ago. It is time for everyone to start meeting with your home officials, meeting with Medicaid folks, meeting with MCAs and your PHAs, right? Sharing your basic 101s with one another, figuring out what each of you bring to the table, leveraging that to impact homelessness. All of these larger entities in your community have money, COVID-related money now, and they have specific pots of funding that should be and can be and are required to be used for services for people experiencing homelessness. Another quick thing, considering who you're going to be prioritizing for EHVs, again, we have a lot, but we don't have enough to give every single person in the community. So you have to think about prioritization. And some things that you should be thinking about as you're mapping out your strategic plan is your goal of making homelessness rare, brief, and one time. So what strategies can get you to that goal? How are your EHVs working towards your already existing system performance measures? How are they going to provide an opportunity for folks who are already in PSH to move on to other permanent housing opportunities if they no longer need the intensive level of support that's in PSH? How can you use EHVs to increase system flow where you're moving folks out of unsheltered and sheltered homelessness quickly? You're reducing the average length of time between coordinated entry and assessment and folks getting into housing, not to mention reducing just the average length of time that people experience homelessness. It's also thinking about providing permanent housing opportunity for folks who, what you call long stayers in your shelter system, right? That also helps to reduce the overall average length of time that people are homeless in your community. And then thinking about, are there strategic ways that we can use these to actually further, and in some cases, actually end unsheltered or chronic homelessness? And as we've shared in previous webinars, we understand that every community has different homeless people and folks who have different situations. So your priorities are going to be different based on both the values that we talked about earlier, the reality in your community, and HUD guidance on prioritization. But something that can be useful is thinking about looking at your data and creating buckets, right, or categories of strategically chosen groups of folks to receive EHVs. Think about these categories based on need, based on the ability of those categories to reduce the size of people experiencing homelessness in your community and to reduce racial disproportionality and disparities. Some categories to think about might be people who are unsheltered. This is a great opportunity to house people living in encampments, which your cities are trying to resolve. Think about prioritizing folks who are disabled, long-term shelter stayers, folks who are older, families with young kids. These are all some possible ways to think about categorizing for priority for EHV. We also recommend that there are certain groups that are not as high a priority. These folks will not have the greatest level of need, and using EHVs to serve them will have little to no impact on homelessness in your community. This includes folks who are already in rapid rehousing, unless They were explicitly put into rapid rehousing as a bridge to PSH and have demonstrated that they will need that ongoing level support. If you target EHVs to these folks, it will not reduce homelessness in your community. Again, it shouldn't be used for people who have been quarantining in hotels and motels unless they are one of those very high needs groups that we talked about earlier. And they shouldn't be used for folks in motels just purely for political reasons, because a jurisdiction doesn't want to be seen as putting folks from motels back into shelter. And finally, as we have stressed in previous webinars and will continue to stress throughout this federal resource series, EHVs should not be used to prevent homelessness. And by this, I mean homelessness prevention and not eviction prevention. Our focus should be to reduce literal homelessness. If your community wants to prevent homelessness, there are funds available, including the Emergency Rental Assistance Program, those coronavirus relief funds, ARPA utility assistance, TANF emergency assistance, lots of other COVID-related resources that went out that can be used and would better be used targeted to prevention. We also know, just as a reminder, the majority of people who are evicted or who leave their housing don't actually become homeless. We can't really predict at that level who is going to become homeless. So if you're targeting resources to eviction prevention, you're not actually achieving homelessness prevention. So when thinking about homelessness prevention, again, get really, really specific and really, really close to the front door of the shelter. Also, I put a link here, and this will be available to you guys in the slides. Whatever you're doing, including eviction prevention and homelessness prevention, you can learn more about those funds listed there and other funds and how to implement them in an equitable way by looking at the framework for an equitable COVID-19 homeless response. Really, really great resource. And now we're going to hear from my awesome colleague, Mia. And I want you guys, as you think about services for the people who receive the EHV vouchers, which is the topic of today's webinar, Mia's going to talk about just some certain considerations that you want to make as you prepare implementing EHV, including checking our biases about who needs what. Go ahead, Mia.
Thanks, Mindy. Hello, everyone. Thanks for having me today. I'm so happy to join you. So I wanted to start off with service considerations regarding the housing first philosophy. So the housing first philosophy is that everyone is ready for housing now. Communities should start off with this belief, this understanding, and approach utilizing these vouchers through the understanding that homelessness is a housing problem. Ultimately, we want to ensure that people are being housed as quickly as possible. Now, this doesn't mean that it's housing only. Some folks, some households that you're serving will need some services, will need some assistance, but you want to ensure that those service needs are unique to each individual household. Some people will need certain services, some people will need different services, and they'll need them for varying amounts of time. You want to ensure that you're able to identify what those unique needs are and be able to tailor them to the household that you're serving. Also, ensure that service participation is voluntary. Services should not be a barrier to folks getting housed. Yes, it is an aid to keeping them housed, but you want to ensure that folks can get into housing as quick as possible so that we can contribute to ending their homelessness. Please also keep in mind that you're not taking a package approach. This is the services package. Again, you're thinking about it from a tailored, individualized way because you want to ensure the ultimate success of the households that you're working with. And keep in mind that some people will just need a voucher and will not need services at all. Next slide. So housing first is essential because housing is a foundational and basic need along with food, water, and rest. According to Maslow's hierarchy of needs, only once these basic needs are met can people focus on their psychological and self-fulfillment needs. Research shows that people are better able to focus on and achieve their goals like obtaining employment, sobriety, maintaining their mental health, once they're housed. So it's essential to start with housing first and ensure that services aren't a barrier to folks accessing housing, and then be able to build on top of that to help them achieve their other goals that will help them fulfill their their sobriety or other goals they might have to maintain their permanency in housing. And so you're not seeing those returns to homelessness. Next slide. So in thinking about individualizing your services to the folks that you're serving, you want to diversify your approach. Perceptions of services might be based in or influenced by your own bias or societal bias about who people are that are experiencing homelessness or particular folks who are experiencing homelessness. Remember that diverse groups will need diverse service needs. Some people, again, might need a short amount of one type of service and a larger amount of others, or they might need services for varying amount of time than others. Again, some might not need services at all. Consider the idea that your idea or your system's idea of service and stability will look different from everyone, and it might look different than the people that you're serving. Your idea of services may not fit the household's idea of services, things that they need. What you consider non-traditional might be very traditional for the folks that you're serving. Ultimately, again, you want to tailor the services to the folks that you are serving. And remember too that the support network needs to be culturally diverse, culturally relevant. Again, your idea of what things, what would work for a household or what might work for your system may not necessarily be culturally appropriate or culturally responsive to the needs of your community. So you also want to consider those cultural needs. Next slide. And you're not doing this alone. We are emphasizing this idea of the collective impact approach. Collective impact is an evidence-based model for collaboration for making social change, and it has 5 common conditions for success. So one, having that common agenda. The common agenda is that it's to end homelessness. Housed people are not homeless. Also, sharing that shared measurement system. So monitoring returns to homelessness after 1 year or 2 years, having those consistent measures. Also measuring equity. So looking at the accessibility of these vouchers or of services to the folks that you're serving and what those race equity outcomes are, monitoring those and having that shared way that you're doing it. Next is mutually reinforcing and equitable activities. So helping folks to navigate the PHA housing process, so reducing any barriers they might have to access the availability of PHA housing process, but then also together individualizing and having a tailored approach to housing stabilization, which are those services that I was just referring to. Thinking about linkages and making those warm connections, so warm handoffs. So creating those linkages and identifying natural and community support, aiding and facilitating that process. The next condition is continuous communication. So identifying what is the preferred channel or process for communication, how often you all will communicate, in what ways, making sure you're using the same languages, especially if you're working with diverse organizations, cultural organizations who are providing these services or systems that you have never interacted with. You want to ensure that you are using the same language, that those acronyms are identified and spelled out. But also, how often are we meeting? How often do we need to meet? How often do we need to talk about the data? And again, just making sure that that communication is constant. To help coordinate and organize this, it's helpful to have a backbone organization. Identify a single organization that can be that linkage for the PHA or landlords to address any service needs or concern that folks have. Next slide. So when thinking about the collective impact model, everyone has an important role as part of that model. So let's talk about the role of the homeless response system. Next slide. The ultimate goal is to house people as quickly as possible and divert people from imminent homelessness whenever possible. So you want to ensure that you're aligning all the system components so that all interventions are focused on the singular goal of helping people quickly exit homelessness in diverse households who are imminently homeless. Communities with the best results are making homelessness rare, brief, and non-recurring. And they have that intense focus on housing people as quickly as possible. They're using a system-wide housing first approach and helping a homeless person or household move into housing and then providing that support or warm handoff and linkages once that person is housed. Overall, this approach allows for better results at a lesser cost so that we can help more people. Next slide. So like we've been saying over and over, it takes a village. So define your role in it. What is your role? The homeless system is part of a network of supports and services, ultimately with the collective goal of getting people from homeless to housed. So the homeless system's role is to ensure that those interventions that we are using to get people housed are scaled using that progressive engagement, and adequately fit and tailored to a person's need. They're accessible to all who need them, and again, tailored to what the needs are. We're making sure that folks are getting housed ASAP and in making those appropriate connections to keep people housed. We're creating those warm handoffs then to community service partners who can provide support for healthcare, mental and behavioral health services, childcare, transportation, employment, so on, so forth. It is not the homeless response system's role to solve poverty or to create the ideal living situation or fix people. We are an emergency service that is providing support to get people out of homeless quickly and begin to establish that foundation. If you're thinking about Maslow's hierarchy of needs, so establishing that foundation and creating those warm handoffs so people can actualize those other goals at the top of the pyramid. Again, and we're not interested in fixing people. We know there are plenty of people who have a number of different issues and barriers and circumstances who are not homeless. So our goal is ultimately to get folks, no matter what circumstances they're experiencing, into housing. Again, you are not in this alone. It takes a village, it takes a community. So utilize those partners within your community, work together, and be able to keep people in housing long term. That's it. Thank you. Oh, I think you're muted, Mindy.
Muted. I am muted. Of course I am. It's Zoom.
You wanted me to keep talking. Thank you, guys.
So yes, thank you so much, Mia, for setting the stage here. Marcella, keeping all of that in mind, the big thing folks want to know about now is like, yeah, Alliance, you're talking about all these services and all of these possible partners in the community. Where are those service dollars? How do I make that happen? And that's what we have Marcella here for today. So Marcella, go ahead and get started.
All right, thanks, Mindy. Can you hear me? All good? All right, sounds good. So next slide, that is our question, where are the service dollars? We've been hearing, oh, there's $1 million here and there's $1 billion there and there's $1 billion, 400 billion going to HCBS. What is HCBS? All of these different languages and acronyms, we're going to try to take you through them. So I hope folks are familiar with CSH. We're a private nonprofit, Corporation for Supportive Housing, national nonprofit, 29 offices, 13 states, helping to end homelessness and make and build supportive housing capacity in our communities. So here's the first thing to know. I've seen webinar after webinar, again, this billion, that billion. Most of these resources, I'm going to drill down on some of them. These are state solutions. So what I've got up on the slide is CSH's analysis of what money is coming to the state of Pennsylvania. We've got this for a number of other states. I've seen it for Nevada, Arizona. People want to be in touch. If we have it for your state, we're happy to share. But it's really important to understand this fundamental piece about government silos, which is that money, when it comes down, comes from the federal government and it goes to particular departments within your state. That's different than how things work in the homeless world. There's the HUD and the SNAP's office, and then it comes down to you directly directly at the local level, like continuum of care. Maybe some funding goes to balance estate, some funding goes to balance estate as well, and that maybe it does, but a lot of stuff goes federal to local. For a lot of these resources, they come through the states. Pretty much anything that's healthcare comes through the states, and then it comes out to the local communities. And states themselves, similar to a balance of state model, may also cover many of the rural communities. So we're going to talk about a couple of different of the funding pots we have related here. That slide's a little low for me. We're not going to talk about the housing ones. We're going to talk about the Medicaid ones. We're going to talk about Medicaid and what's called home and community-based services, or HCBS. We're going to talk about HRSA funding, in particular health centers, and I hope you all have your healthcare for the homeless partners that are part of your continuums of care board, that are partners on projects. They have a lot of skills, a lot of resources, new funding as well. They've been incredibly challenged throughout this COVID time of COVID, but they also have some new resources. And then we're going to talk about SAMHSA, behavioral health and state related there. Amanda, I'm sorry, we do not have an office in Missouri. I don't have an infographic I can send you, but we'll give some links here that might be able to help you put something like this together for yourself as well. So think about, as we begin this next conversation, think about, who are my state connections? Who are my state connections in the housing and homeless world? Who are my state connections in the healthcare world? How do we help them become part of our, what I like to call the coalition of the willing, around our priorities around ending homelessness? Also know that you have new resources. Everyone on the healthcare side perspective is, oh my gosh, we just figured out in the last 5 years that there's no housing or not enough housing. And what are we going to do about that? They're looking for you. They're looking for new partners. The buzzword in the healthcare world for, hey, we should think about housing and other basic needs of people, that first level of Maslow's hierarchy of needs, as Mia talked about, is social determinants of health. So if you are working with a health plan, if you're working with a hospital and they have a social determinants of health director or coordinator, you want to connect with those people. They're the ones who in the healthcare world are minded in your ways. The second buzzword that I want to give you is also population health. You see public health and other healthcare entities that are like, oh my gosh, our role is to look out for the health of all of our communities. We know that people experiencing homelessness are some of the people who have most health conditions. How do we partner with you? How do we build with you? How do we take our strengths, which is services and billing for services and delivering services, with your strengths around homelessness and housing? So next slide, please. So these are some of the foundational questions you should ask yourselves. One is who? Map your network. And what I mean by that is, who are your partners? Who do you know? Who's already built in completely in housing? Who's already built in completely, who's kind of gets it on services, but needs to be sort of brought along? And then who we don't know at all, and they don't know us, but they need to know us because we need to build the partnership. So locally, you have Medicaid and at state level, and then managed care organizations. Managed care can be statewide. I'm thinking about Indiana, and there's 6 plans now. Managed care can also be regional. Managed care can also be county. Do you understand that system in your community? Do you even know who the healthcare managed care organizations are for the individuals you're serving? If you have a large concentration of their members, they're going to want to work with you. They're going to want to support you. So think about managed care, understand the basics in your system. Health centers, healthcare for the homeless, but other health centers and partnerships, what can you build there? Let me highlight, health centers know how to build and have the infrastructure to know how to build. We're going to talk about Medicaid funding supported services before we get to the end of this webinar, and a lot of agencies are really struggling with the billing piece of it. Of course you are. Health centers know how to bill. Are there partnerships that you can build there together? Health centers want to learn, how do we house the people who are coming to us for services? How do we contribute to social determinants of health? How do we improve population health? You have strategies on that, whether you know it or not, around ending homelessness, around access to housing and housing related resources. Behavioral health authorities, this is where I came from. I'm a psychologist by training, but I worked for for Philly's Department of Behavioral Health for many, many years, because it was like, how do we take the resources that we have under behavioral health and all those new SAMHSA resources and help reach our agenda of ending homelessness? Sometimes on that other side, you're going to find true believers like myself, and then sometimes you're going to find people who need to understand, who need you to kind of bring them along. Do you realize, oh, your goal is around improving population health? Well, if you helped us end homelessness, population health would improve in your community. Oh, your goal is around addressing equity. Did you realize how overrepresented people of color are among those who are experiencing homelessness and those impacted by mass incarceration? If you want to improve equity in your community and you help us end homelessness, we can work on this together. So you're making those arguments, you're making those relationships, and you're building those joint projects. Public health authorities is something that really wasn't even on my radar before COVID. Public health looks at things from a system lens. Public health is a really good partner to a continuum of care. Public health is not your local hospital. Public health is not your local MCO. Public health is not your local doctor. It's the health department that is looking at things from a system lens, and how do you partner and work with them as well? They want to improve health throughout the entire community. If they're a partner with you around ending homelessness, they're achieving their mission as well, which is improving health in the community. So among all of these people, who do you know? Who do you want to know? I started as a case manager on an assertive community treatment team, and literally I got invited to a housing meeting because my boyfriend at the time was running an outreach team. So these can be formal networks, these can be informal networks, but who do you know? How are you connected? And how do you set them? What tables do you have to be at to help them set their priorities? Oh, we want to address the overdose crisis in our community. Well, how many people are experiencing homelessness or housing instability, who are overdosing, who are addicted to opioids? We should be at that table in order to help you address the opioid crisis, and you should be investing in our solutions around ending homelessness to address the opioid crisis. You have foundational questions you need to answer for your continuums and your services around what do you need and what do you come from? It's not enough to say, we want services, we want more housing. It's important to say, we have 10 developments with 200 units among those 10 developments, and they're going to be serving people with behavioral health needs. Where is behavioral health with the services? So you're going to need to quantify that. And what services do you need? Do you need tenancy support services? Do you need case management? Do you need assertive community treatment? Why are you making these arguments? What research and data do you have behind you? Quantify your need. Don't go in with especially after you've built the relationship, go in with very specific asks that say, we can put the emergency housing vouchers on the table. Where is the services and how do we build that? You want to find overlap between agendas. I just gave an example of that in the overdose crisis. You want to know their pain points, what's difficult for them. I will tell you, every MCO has people in hospitals, people in acute care. They don't want to send them back to shelter. They don't want to have them experience homelessness, but they don't have housing to go back to. They want to learn how to address that issue. You in many ways can know how to address that issue, but you're leveraging the partnership. You're not just handing over resources, you're building relationships, networks, cross-sector referral systems, and you're leveraging those partnerships. So you bring strengths, you bring needs as well. Come with data. Yes, Mindy's point I'm saying in the chat is exactly. Talk about how your activities can serve their agenda. Your singular agenda, if you're listening to NEH, is ending homelessness. Maybe that's their singular agenda, maybe it's not. Find out what their agenda is, and if homelessness is ended, how much does their agenda move forward as well? Have we improved population health? Have we addressed health equity and equity in general in our communities if we've ended homelessness? I'm sure the answer to those questions is yes. You've got to get specific. And what I will also say is that, especially on the healthcare side, they want very specific answers. That national data, 15 years ago when I was doing this stuff at local aid, national data was good enough. Everybody wants local data now. If I'm building a project in Florida, I want to know what this means for Florida, Florida's healthcare system, Florida's MCOs, and I don't really care what it means. I definitely don't care what it means for New York and California. I might care what it means for Texas from Florida. Think about things in those political terms as well, and make sure that you're building those shared agendas across and how you can help. And then what do you have to offer? You have emergency housing vouchers now. You understand the homeless system. You have data. You're leveraging your data. You're not just coming with data, but you're leveraging with data. Communities that have done FUSE, frequent user system engagement projects with CSH, has merged data between homeless systems and other healthcare and jail and other multiple systems. Use that data in order to leverage the need and leverage the investment on the services side. And then you also have to think about timeframes. You have to think about the fact that you need to get these EHVs out very quickly over the coming months. That's wonderful, that's incredible. But also think about this in terms of, I need services now, and I need to build long-term relationships with these systems. Because the president's budget put forward, I believe, there's 70,000 EHVs that are hitting the streets. There's 200,000 vouchers that were proposed for the president's budget. I don't know what we'll get. That's certainly not finalized, but know that you're not just planning for now, you're planning for these, and you're wanting to build these cross-sector referral systems. And so look at it as systems lens, because as new resources come down the pike, those are going to need services as well. Certainly as we look at the aging population, I'll say this again, it's an acronym everybody in the homeless world needs to know: Home and Community-Based Services, or HCBS. So understand their money, understand their processes as well for your partners, your new partners. How is the funding flowing? For how long? You've got to match up all those time frames. How do you bring the systems together to serve everyone more equitably? Raise up the data that you have in your communities, or I hope you have in your communities, about the disparate impact of homelessness on communities of color, the disparate impact of mass incarceration. Everybody, a little more than a year ago, after George Floyd said, we're going to be anti-racist, we're going to do something. If all they did was put out a letter, that's what we call these days performative allyship. Now you have an opportunity to help them move beyond performative allyship. You have an opportunity to say, you want to address inequities in your community. Here's a way, help us end homelessness. And again, this is a short-term goal around your EHVs, but you're also building systems between these networks and between these sectors for new potential money that's coming down the road. Next, so these are the foundational questions. Ask for yourself as you begin to approach these new partners. And as you've mapped out your network, ask yourself these questions. So this is one of my new favorite slides, et cetera, because think about how multiple sectors are negotiated. The person in our community, I always used to say, and Billy, it's better to have one problem and be the sickest person with one problem than it is to have two little problems. Because when you have two little problems, you become this hot potato between the multiple systems. Our current reality is that cross-sector work, the burden for cross-sector work falls mainly on individuals and families. If I'm homelessness and I have a substance use problem, I go here for my housing or my shelter, I go there for my addiction-related treatment or assistance, et cetera, and I've got to negotiate those. The future vision is that burden falls not on individuals and families. That's why they're falling into the homeless system, but that burden falls mostly on government. It falls a little less on providers. Government sets up ways in order to braid the funding. We're clearly not there yet. All this money is coming from ARPA and CARES Act, and it's not braided. It's each coming down into its own silo. Good providers can pull from multiple funding streams, et cetera, but the real burden continues to lie with the individuals and families. And we really want to build systems where we flip that vision, where the burden for negotiating through multiple systems and pulling money together from multiple pots lies mostly with government, lies second with the providers, and lies least of all with those least able to, the individuals who need the services and help. So yes, so next slide, please. That's where we're trying to go. So think about where do cross-sector partnerships strategically begin? And we would say that there's really three ways, that they begin. We've got a link here to CSH's cross-sector partnership roadmap that's focused on homeless systems and child welfare, but the content may be slightly different from other systems, but the process is very much the same. One, you want to have joint priorities and goals. That equity goal that can be joint between your homeless system and a healthcare system and a local hospital system and an MCO, and a state Medicaid office. You want to build those joint priorities, including populations. As you look at your data and say, oh my gosh, the number of aging people who are coming through our doors in the homeless system has just skyrocketed in the last year or two. You want to reach out to those aging systems, to those home care providers, to those Medicare Advantage plans, et cetera, and find out what are those joint priorities and populations. How do we build joint projects, and how do we build the scale? You want to build common networks. You need to know these people. You need to work with them. Commonly joint projects start small with a pilot. Maybe I go to, somebody's, I heard today from a managed care organization, they're on one continuum of care board in a part of the state, and they're committed to getting on all the continuum care boards across the state. That's building the common networks, but then they're also taking to the next level and they're doing investments as well. So you need to know the people, you need to make the connections in these other systems. You need to understand, as we said, their pain points and how you can help move their agenda forwards as well. It takes time to build strong, trusted relationships. It's one thing for an entity to send a staff person to a meeting. It's another thing to build a pilot project. It's another thing to build towards scale. It's an even different thing to jointly push on a policy. On a policy end. So these are all examples of ways that you can build those partnerships and build those networks. You may not get a huge chunk of money for emergency housing vouchers in the next 2 months, which is when you need them, but you're building for the future as well. I want to make a point again about cross-sector referral systems. Managing these multiple systems shouldn't lie with the individuals. We want to flip the pyramid that we just saw. It should lie with the government and with the providers. And so help them understand this is particularly for folks in government, what are these different pieces that you need to bring together and build those cross-sector referral networks, build the priorities, build in systems that say, okay, your priority is chronic homelessness, your priority is families, your priority is eviction prevention, and their priority may be working with people with high cost, high needs, people with complex care needs. How do we intersect those needs? How do we share data to find out how many people are in both? And then how do we target the resources we have to that? If you target the resources and address their pain points, they are much more likely to come to the table and say, here's some resources, here's some funding. We're going to do that as well. We're going to do it with you as well. The homeless sector, much more than the healthcare sector, is much more savvy and sophisticated around the equity conversation. We are nowhere near where we need to be, but gosh, I think we're a lot further than healthcare. So really push that message. Again, we said, give people the opportunity to move beyond performative allyship and help them talk about, you really want to make sure this equitable distribution of the resources that you're managing, the emergency housing dollars. My second question is, what are the equity goals around these healthcare dollars, this new home community-based services, behavioral health related services, health center services, et cetera? How can we merge our resources in order to meet all of our equity goals? And then plan for the future. I hope COVID has been such a tough time for people. The closer you are to the ground, the harder COVID's been for you. I hope you've taken some time. I hope you've taken some vacation. I hope you've taken a breath, because this is not just the moment, but also plan for the future. I'll say again what an old mentor said to me: remember, this is a marathon, not a sprint. So take a moment, breathe, congratulate yourself for making it to July of 2021, and then think about how you plan for the future as well. And then I can't say enough about data integration. How can you leverage the data you have? Health plans, health offices, health systems, they desperately want data on who's homeless in our system, who's housing unstable. They want to understand the homeless definition. They want to know what you can do. And all of this needs to be in place in order to, if you can leverage your data in that way. And then again, go back to, what do you need specific ask? I need services money. Well, that's a good ask, but a better ask is, I'm serving in 25 units, I'm serving 25 households. This many are singles, this many are families, this many have behavioral health related issues, and I need an on-site clinician to serve their behavioral health related needs. That's a much better ask than the very generic, I need services money. Quantify cost, budget, and know your strengths and be able to act. When somebody says, oh my gosh, I've got new funding here from our SAMHSA money that's coming down, I need it to be for behavioral health issues. Do you have a mix there? Be ready with the data and the information to say, you're a good partner, you're ready for that opportunity. Next slide, please. Take a minute and breathe. All right, let's get into a little bit more detail about what these pots of money can do and how they work. So one, Medicaid home and community-based services. This is your state Medicaid offices. Your state Medicaid offices have been offered a plan, offered a deal, if you will, from the federal government. Medicaid is a joint state and federal program, and feds have said, on average, Medicaid is 50% state funded, 50% federal funding. When the federal government wants to influence the states and get them to make certain policy choices, they do what they always do, which is say, well, we'll give you a little more money if you do it our way. In Medicaid parlance, that's what's called an FMAP bump. Federal medical assistance percentage goes up. For home and community-based services, states have the ability to get 10% more money of the feds and then take the money that they're saving and put it into new projects, new programs. You want to meet these people, you want to know their networks, and you want to say, hey, tenancy support services has been determined by the Center for Medicaid and Medicare Services, or CMS at the federal level. Tenancy support services is a home and community-based service. Is that covered in your plan? Is that covered in your state plan? And can we do that? How can we offer that? I'll talk a little bit later about what states are doing that and where they are in that processes. But states need to include housing support services in the plan. Gosh, I can't, Mindy, I can't even, I'm gonna have to get glasses here. All right, so what activities you wanna learn? What's your state? Is your state going for your FMAP bump? I don't know if you can make it any bigger. What activities is your state doing to get their FMAP bump? It is aligning at all, previous slide. I need that slide. There's a lot of detail on these. I'll tell you, I need my slides. Second, I got it. Thank you. I hope you guys can't see my paper over here. So what is your state doing to get their FMAP bump? What activities are they doing? And are they serving various populations? Every state has some kind of home and community-based services. It differs state to state. They cover certain populations. Most states cover people that are aging. Most states cover people with intellectual and developmental disabilities. Other states may cover others. And most states do different other services, have different service arrays. Let me say that most of the service arrays are focused on people who could be an institutional level of care and keeping them in the community. These are in-home community-based services that help people stay in housing. Again, the thinking though is that it's mainly the reason they might leave their housing is they have to go to institutional care. Many states, and we'll talk about which ones, are now implementing home and community-based services, housing support related services. So what's your state doing on that? Figure that out. And then are the services aligned with your housing systems? I like to say if everybody who's getting home and community-based services has to stand up on their right foot and everybody who's getting housing has to stand up on your left foot, then you have no alignment because everybody's on the ground here in that metaphor, etc. But and are you at the tables where the state is deciding, here's the populations we're going to cover, here's the services we're going to cover, here's the access we're going to cover? Somebody from the homeless world needs to be at those tables and say, this is what works for us and this is what doesn't, and make sure those change. So there is SAMHSA money that's coming to states. States also have to submit plans there. SAMHSA, the Substance Abuse and Mental Health Services Administration. That money went to your state mental health authorities. That money went to your state drug and alcohol authorities. Sometimes the state submitted plans. Sometimes the state pushed it out to the county systems, etc. But who's getting that money? Are they partners? Who's invested in ending homelessness with you, addressing housing instability, addressing over-institutionalization in your communities? If you see and if you have data that says people with behavioral health issues are overrepresented among those experiencing homelessness and housing instability, get that data and get to those tables. The system I used to manage in Philly, our unsheltered population, we thought about 90% of them had behavioral health issues, and our outreach system was completely funded by behavioral health. So they've got new options and new opportunities there, but you've got to come to the table with the data. These are services for people with serious mental illness, for people with broader mental health challenges, for people with substance use disorders. You probably want, as we like to say, a spy on the inside, somebody who understands those systems, knows how to work those systems, and can see that intersection as well. And then is there a cross-sector referral in place? When somebody's experiencing homelessness in those systems, what happens? When they're moving people out of state institutions, when they're moving people out of hospitals, where are they moving to? Understand those systems and see what resources what do you understand from a housing perspective that you can assist with, and how do you partner there? It can't just, the most common mistake I've seen is people coming in and say, it's either all about homelessness or nothing. And I understand that. It is just the most urgent crisis there is, but trying to make friends here, you're trying to engage, you really want to understand what their pain points are as well, and build those partnerships so you can jointly address them. That's when they make that's when those other systems make investments. And then Medicaid also has demonstration waivers, what are called 1115 waivers. There are a number of states, Arizona, Vermont, gosh, a couple of others who've asked Medicaid to pay for housing. We'll see how and where that goes. My guess, and it's only a guess, is that we'll end up being much more of a partnership model than having Medicaid pay for housing. But they are desperate housing needs in the healthcare system and the Medicaid system. They want to learn what you know. They want to have access to your data. And you can offer that if the price is right. So you are not the poor relation in this negotiation. You are coming with your data. You are coming with your resources. And you need to say what you're going to get. You are trying to make a deal there. Next slide, please. So there is also health center funder coming. As I said, it's to help them with all of the challenges they've had through COVID, whether it's PPE challenges, whether it's people not coming in for services, because for so long there we didn't want to go anywhere outside of our houses. We were all quarantined, which means we weren't making our doctor's appointments, which means our health centers weren't billing for the services we weren't getting. But so they've got a lot of new funding there as well to address a lot of those needs, and I want to acknowledge those needs. But I also want to say that they're probably have potential for some other partnerships with you. So how do they offer health services? How do they use their billing mechanisms? How do they deliver services to the people in your housing billing there? Think about what strengths they bring, what unique strengths they bring, what knowledge they bring, what data they bring, and challenges. They're required to collect data too around homelessness and housing instability, though they define it differently than the HUD homeless world does. But use their data, pull your data with theirs, and see where you should be working together. And then think about other services aligned with the housing systems. Do they just offer clinic-based services? If you can get people to them, they'll get quality services. Or is there any kind of outreach, community-based services, other potential there? And then finally, and this is one I don't think pre-COVID was on our radar, is the Center for Disease Control. They're getting a lot of new funding for our local public health departments are getting a lot of new funding for community health workers. These are community health workers are individuals who come from the community, have chronic healthcare needs. They know how to negotiate these systems. Think of them as like peer support coming from behavioral health or the homeless systems world. Think about the Speak Up advocates that CSH has supported and built out. In the medical world, they're called community health workers. They're from the community. They know how these systems really work. And the CDC is funding a huge new flanks of these workers across the country. They'd be a great addition to your supportive housing project, to your shelter. Many of them, my guess, has experienced homelessness themselves. That's certainly what we found when I was working locally and more closer to the ground. So are you partnering with public health? Public health is trying to figure out, how do we make sure everybody gets vaccines in our community? How do we address this evolving disease known as COVID? Public health is getting new resources to do more work with what they would call vulnerable populations. So public health wants to partner with you. Gosh, if you do homelessness work, you have a vulnerable population. Public health has now declared racism a public health crisis. We would absolutely agree with that. And we would say we have strategies around addressing equity that have to do with ending homelessness, addressing mass incarceration, addressing individuals who are over institutionalized. I'm in a nursing home, I could be in the community, things of that nature. So there's a lot of intersection points here. Again, these are questions. These aren't answers. You've got to build that network within your community. You've got to build that coalition of the willing. Your public health authority is also beginning to work in social determinants of health, educate them, help them understand your systems, what they have, what they don't have. I'd like to think that we're past healthcare thinking that there's enough housing out there. They just don't know where it is. But maybe you need to educate them on that as well. And then build on the relationships. My guess is a lot of you have new relationships with their public health sectors coming from the work that you did together around COVID, the work that you did around quarantining. Build on that relationships. It's great if the immediate quarantining crisis is we're past that. I hope we're past that in your community. We are in mine, but you know people now. You know their priorities. You've built some relationships there. Build on that as well. Next slide. I'm not going to spend too much time on this one. I'll just highlight the high level here. But these are a couple of cross-sector activities that you can begin to work with as you're working with these new entities with your new funding for EHVs and their new funding, which can be targeted to services. Data-driven problem solving, you want to match data between systems. You want to do something like CSH's Fuse model, and you want to see how much overlap there is. It's my experience that people in the healthcare world and the public health world vastly underestimate how many people are homeless, how many people are experiencing housing instability, and they need your knowledge and expertise there. The policy and systems reform, it's one thing for me to say my system is underfunded, please pay me more. Let's say I'm in healthcare and I think my system's underfunded. It's another for the housing system to come along and say, please allow healthcare from a financial perspective to deliver services in housing. Please allow them to do more community outreach. Please allow them with their funding to do this. We make great partners on the policy and systems reform, especially when we advocate for the other, not for our system, but for the other. Some of our best advocates right now for these new expanded vouchers are the Medicaid managed care organizations who are like, we can't find housing. We've got people in the hospitals. We don't want them in the hospitals long term. It's not good for our bottom line. It's not good for their health. It's not good for community integration, but we need more housing in order to help more people out. So joint policy initiative excited there, and that target housing and services to those most in need. Other sectors can become our best advocates. That's absolutely true. So I've talked a lot about Medicaid, in particular about getting funding for services from these other entities. Next slide, please. And in particular, I've highlighted and said Medicaid can pay for housing-related services, not for housing-related services. But again, Medicaid is a state joint federal program, which means that the feds have already said Medicaid can pay for housing support services, the services in supported housing, case management and shelters, other opportunities. So your next question becomes, where am I from? And does my state's Medicaid plan cover tenancy support services, housing support services? In Washington state, this is called foundational community supports. In Minnesota, it's called housing stabilization services, but you want to know that. CHH does a regular update on this, and I'm happy to share that with folks if they want to be in touch. But you're asking this basic question, does my state's Medicaid plan cover the services? You've got a list of states where the answer is yes. You've got a list of states where sort of. So Washington state, Minnesota, North Dakota, Connecticut, New Hampshire, and Illinois have all requested it. We hope to hear a yes soon. We'll hear a yes in some way, I'm sure. Hawaii and Rhode Island, all of those, the answer is a yes. You may not know how to connect to that. You may not know how to pull down those dollars, et cetera. That's something your agency should begin to be exploring if you're in one of these states. There's another group of states that what I call the answer is sort of. Some states have it by region. So Florida and Maryland, there's some counties or regions where you can pay for that, and there's tenancy support services and some where you can't. Louisiana, Oregon, and Pennsylvania, I would say yes for some people. In Louisiana, it's primarily, though not entirely, people with serious mental illness. In Oregon, it's actually their new waiver for individuals with substance use disorder. Pennsylvania has tenancy support services for IDD, folks with intellectual and developmental disabilities. In Massachusetts, you could get paid for what Massachusetts calls flexible services if you can get a contract with an accountable care organization or an ACO. North Carolina and California also have some counties, some places, some pilots. Arizona, Colorado, and Vermont have all requested this. If you don't see your state listed there, as Mindy or someone in the chat had said, the answer is why not? And we're happy to help you advocate for that and give you answers. States love examples from other states. Everybody wants to be, except for Washington state, but everybody else wants to be the second state to do it. And those much easier negotiations with the feds when you can point to, but Washington already does it, but Connecticut already does it. This is how we do. I will also say the administrative burden on an agency for stepping up from grant funded services to Medicaid funded services is a huge step up. CSH is actually advocating at the national level for what we call our Supported Services Transformation Fund. It's asking to make sure that every state offers housing support services, but it's also asking for two other really clearly. two other buckets of money. The biggest bucket second bucket of money is to give agencies the capacity building that they need. So know that this is a long road you're going down for Medicaid for services, but it's the road that most people are going down. It's the road that Minnesota, Washington, others have already gone down. It can really be a challenge, but it can also be, but it is what's going, it's where we see development going. It's what we see most fruitful. So yes. There, yes, and then next state. So next slide, because I always like to end with what are your takeaway messages? So here's what I would say. You should leave this webinar and think about this and answer these questions for you. And I'm sorry this webinar has come with lots of questions for you and not many answers. The answers are different for your state and your community. The best answer I can give you is build a coalition of the willing and define your priorities. Your priority is ending homelessness. We know that. You wouldn't be here if it wasn't. But the question is and aging and behavioral health and keeping people out of institutions and addressing mass incarceration and building equity in our communities. What else? Strategically gather your partners. There are things you do well, there are resources you have, and then there are things you don't know about. There are things you're not sure of. Nobody understands all of this work. It's too complicated. And so strategically gather your partners who are weak where you are strong and strong where you are weak. You are building for the present. You want those EHVs vouchers out there. You want people living in housing successfully in the community. You want to reduce homelessness because of those EHV vouchers. And you are building systems with these other sectors over time. So you are building for the present and you are building for the future. Think about that in terms of networks, in terms of relationships, in terms of processes, in terms of technology, and in terms of outcome reporting and impact. And then finally, assure that equity is foundational. There is such a push right now from the Biden administration, from communities themselves, and from everybody and all of us in between. Ensure that equity is foundational to all of the work that you are doing and all of the partnership work you are doing. Let that be your opening. Let that be the key that opens these doors. Let that be your calling card, and make sure that is the center of what you do. And with that, I think I get to take a break and a sip of water and see what other questions. Q&A coming up. Mindy, I hand it to you now, right?
Yes, coming back on. We are also really glad to have our colleagues Mia and Kay join us for the Q&A. So if you guys want to start your videos or not, Zoom fatigue is real. Social anxiety over the internet is also real. Respect that. Thank you so much, Marcella. Thanks, Mia. Thanks, Kay. Everybody for lighting it up in the chat. Lots of helpful hints, lots of great information. And we'll go ahead and get started with some questions. So Marcella, like you, everyone else, we all have so much on our plate right now. You definitely covered a lot of helpful information. For folks who are listening today, like what's the very first thing they should do tomorrow? What I loved about your presentation is it got really like concrete. So how do folks get started tomorrow? Especially the MOU for EHVs is in 3 days, but this is again, a long-term project moving forward. So what are we doing tomorrow?
So I think tomorrow we're looking at our data and seeing, okay, we want to end homelessness and what does our data tell us? Do we want to focus on aging? And that says we're reaching out to this group of people. Do we want to focus on IDD and we're focusing on that group of people? Do we know that these healthcare leaders in our communities are focused on health and housing? And we say, wave your hands and say, hi, we're the housing people, etc. We understand these systems, we understand these priorities, we can educate you, but we're going to need resources and support to do that. And again, quantify that ask. So that would be my thought.
Thank you. And we had a very specific question, and Marcella, you can take this one. Kay, I would also love to have you chime in because you've had that experience of working at the local system level, at the program level, and now at the national level. This is one from Lita at Community Partnerships for Mental Health in Washington, which is, and Lita, I don't know if you mean Northeast Washington, DC or the Northeast of Washington State, but either way, that there's an issue with PHAs requiring documentation, and that for folks who may have SMI or other serious behavioral health issues, not being able to process to handle those kinds of more administrative processes. I'll just say, I think this is one of the areas where a COC can say, here's something beneficial we bring to the partnership, right? Like COCs, folks who work with people experiencing homelessness, know how to handle helping navigate administrative barriers. And so, hey, PHAs, we bring this to the table. But I would love to hear from you guys kind of your perspective on that. Because we want people to focus on those who need, who maybe have the highest barriers to stability. How do you help them navigate what is going to be these other systems that maybe don't have that expertise in folks who need assistance navigating barriers?
Yeah. So Marcella, I'm willing to jump in here and then you can follow up. So because I just was talking to a community yesterday about, some of the work they're doing and what they're, how they're working on services. And one of the things that they said is, one of their biggest concerns is that with vouchers, that they've already created a partnership. The good thing is they already have a partnership with their PHA. They've already been prioritizing some vouchers. But what can happen is that somebody is given that voucher, they're given an appointment, and then the follow, they get rejected because of one question not answered on the form, or one thing that's not filled out, or something that they should have taken with them. And so one of the things that they're looking at doing, and just that learning process that I think we could all benefit from, is that, when you looked at that list that Mindy talked about earlier, like here's the different, folks. If somebody's, a long stayer in the shelter, there should be a shelter case manager, right? That's aligned with that person. If somebody, is being referred by outreach, and you're looking at unsheltered folks, there should be an outreach team member. There's people already in our system that should be walking along beside those persons to those vouchers. Our suggestion would be that the one way that what we're good at is supporting our folks and getting connected, the warm handoffs that we talked about. And just because they have a voucher and we've got a partnership with the PHA and we get them in for that, there's an appointment and we send a reminder out. If we want to make this quick, and there's a lot of incentive, and Marcella already talked about this is about doing it very quickly. Think about what are those barriers to making it happen quickly. Just exactly what you talked about, Leila, was, folks that just they miss a piece of documentation, or they may not answer something right, and that they get thrown on the pile, and then we move on to the next person. So I think really be strategic in your communities and come up with a policy, a plan. Let's not call it a policy. We don't need policies. A plan for how you're going to do it. And I think, again, that's exactly what Mindy said, is it is one of the things that we can then offer to the PHAs, right? Like, we are going to make this easier all around, that we're going to be there and make sure that we know what you need. And so having those conversations in advance to make sure that our folks are ready and that we've got support with them going there. That would be our suggestion.
Yeah, no, I can't. That's absolutely right. You're reminding when I managed a project between PHAs and the COC, the PHA suddenly, everybody needed a piece of paper that said this is why the person was being, sort of basically, moving beyond the wait list, et cetera. And they wanted a form that everybody signed that said they were coming from the COC. And it was 600 forms we needed at that point, because we'd moved 600 people so far. And my answer was, sure, we'll give you a form. We'll make it up. We'll get it all signed. We'll make it happen. You're invested in getting these folks housing. You're invested in getting these folks out of homelessness. What do you need to do to make that happen? That can-do attitude is what always
exactly. Yeah.
Always informs the homeless system. Let me also say that you are looking for new funding from these health sector partners and others, because it was easier to do that with 5 case managers than it would have been with 1. And let me also say that you're educating the housing authorities around what are the needs. You're educating the housing authorities on what are the services needs. I look at the housing costs in the Bay Area, where I was a week or two, and I think, oh my gosh, I could be homeless with what housing costs in the Bay Area, and CSH pays very well. So, educating people on who's homeless in your community, what their their needs are, how you've connected to services when that's needed, and how you're just making sure affordable housing is available to them as well. There are many, many people with disabilities who live independently in our communities, and they do not have in-home services. They're connected to community-based services, but their great need is affordable housing. So these are some of the stigma that you're trying to address around service needs, around aging, around behavioral health, and you're educating the, what was I going to say? And you're educating, if you're coming from the COC, you're educating your housing authority partners on this. But you're also hopefully leveraging your networks that you've been able to build up in the services world, in healthcare, in behavioral health, in HCVS, and saying we can bring these other partners to the table. Let's all work together.
Great response. And I want to share something with other folks. You guys pop in the chats. This is Marcella clearly is an expert on this topic. Those of us at the Alliance have different, wear different hats and have had different experiences in communities, and we have a perspective, but you guys also are experts in doing this work, and we want to hear from you. For example, Deirdre says, forged PHA partnerships, COC providers can offer supports for client referrals via pre-application checklists, gathering documentation prior to referrals and voucher meetings. PHAs also can and must build in solutions for the what ifs that support the overall efforts to move folks into permanent housing. And I think that's a really important thing to bring up is like we all know, Marcella, I loved the pyramid that you had, and it's nice because it kind of harkens back to the Maslow's pyramid, right? Like right now, the burden for getting all of this stuff done tends to fall on the people who have the least amount of emotional resources to dedicate to administrative barriers, right? Like they're working on just not being homeless or just getting food for the day or staying safe. So we need to be able to flip that. And one of the great conversations that we had on one of the earlier webinars with the Richmond, Virginia COC and their partners at the Richmond PHA was talking about, we all have a shared goal. It's finding out what are the words we use to describe those goals, right? And once they started having those conversations, they do have a shared goal. It's about getting people into housing and keeping them in safe housing, right? And so then what does that look like? And being able for the PHA to understand, like having, like Deirdre talked about in her comment, the PHA also needs to be flexible enough to say, oh, this documentation thing didn't happen. That doesn't automatically mean that someone, bam, loses their opportunity to get into housing or a voucher. And working with COCs in partnership on that is going to be key. We had another question, and Mia, I'm gonna say a little bit about this, and I'm gonna put a link in the chat, but then I would love for you to talk about it too. Someone asked about ideal housing, ideal living situations. It seems like if we're going to serve people effectively, we have to give them what they need to be successful in housing. Where is the line between setting up someone for success and creating an ideal situation? So I think one of the things that you talked about early on, Mia, which is just kind of this challenging our own biases, which can be uncomfortable to do, right? Like it's not fun, but what is it that we think someone needs to be successful in housing, and how are we defining success? Letting folks tell us what they need, but also having a reality check. I'm going to put into the chat a recent blog that we did on shared housing. And we often hear in communities, there's so much pushback against shared housing for people experiencing homelessness, which is so weird to me because it is how we all live. Almost all of us on this call today live with another adult human being, right? Almost all of us do. And like Marcella was saying, especially if you live in San Francisco or DC or New York City, you are living with other humans, even those you're not in an intimate relationship with, well up into your older adult years, because housing is just so expensive. Why don't we think that's a good option for people experiencing homelessness? Some of that has to do with our own biases. Some of it has to do with how it's framed. What's an ideal living situation? For me, that's me planning out 30 years from now, right? Like it's not where I am right now, it's where I am right now and how that helps me get to the ideal sometime down the road. So Mia, would love to hear you say more about that kind of like reframing about what's ideal, what people need.
Yeah, absolutely, Mindy. I think it has a lot to do we do with bias, we do have to check our biases on what are our goals that we're placing on folks that we're serving. But I would also encourage you to rethink what your role is. What is your role within the homeless response system? It's not necessarily to set someone up with, what would be better, what they would like in terms of, a two bedroom house that they own, things like that. Maybe they can work with a shared housing living situation temporarily while they work on some of their longer term goals that may take a little bit longer to accomplish. And so again, just from seeing the homeless response system as an emergency resource that is ultimately trying to end someone's homelessness. Once someone is homeless, then they're better able to accomplish some of their other goals that will lead them to more ideal situations. We just want to make sure they have a safe place to call home and that they're not returning to homelessness. And that is the foundation. We're here to establish that foundation, and then folks can build up on that as well. So again, check those biases, but also remember, what is your role in all of this?
And I just want to add that, even the setting up someone for success, is that our determination of success, right? And, how do we define success? So I think again, the biases of, we tend to, in this field, use a lot of these things like someone's failures, someone's successes. And, and this has been a long lesson, a long journey for myself, is that I'm here to end your homelessness, as Mia said. And this is a jumping point. It's a place for you to start once you're out of homelessness, and messaging that. It's also reality checks that most of us, we have reality checks in our housing situations all the time, even for those of us, that are not living in poverty, because there's still things that I would like as my ideal situation, but that is not a reality check for me. And so I think we have to be really careful when we use, our languaging about our concern about success and about failure. We're talking about somebody ending their homelessness and having sort of that jumping point, and also messaging that to our folks, right? That this is a starting point from where you can start working on the other things. And this is not your housing long-term. This is getting you out of homelessness. And it's not, how many of us are still in the housing, that we started out in? I've moved multiple times, right?
I am not, thankfully, really thankfully.
So
Woo!
yeah, I basically lived with a bunch of people in a one room efficiency, as an adult, to make my housing affordable. And so I think we have to remember that. So I just wanted to add that.
If I can also just say, even in bringing it back to the services, when we're thinking about barriers, also defining what do we consider barriers, because someone who does have, a certain type of disability or an addiction or whatever their situation is, that may not be a barrier to them getting housed. I know folks, you do want to be planful, you do want to be mindful to have those support services and resources available to those that need it, but be very mindful about, how you're approaching, someone, or kind of predetermining that someone's situation is a barrier. You want to make sure that you're working with folks to identify what their needs actually are, because not everyone who has certain or are in certain circumstances have the same needs.
Thanks so much. Great conversation, y'all. And yeah, the shared housing conversation is blowing up in the chat. To kind of bring it back to the EHV and services conversation, Marcella, I'm going to put this one to you. It's about shared housing, but it's also about folks with serious mental illnesses or behavioral health issues, and a perception that some of us may have based on individual experiences with clients that folks with SMI or folks with behavioral health issues don't want to shared housing. I will say, from my perspective, it's all in how you sell it. And Marcella, I'll let you talk about that, particularly from your experience on the clinical side of things.
Yeah, so I would say this. My brother, who's an English teacher, says we should never use the words all or never, because they're almost never actually accurate, etc. So, and I would have to go with that. I think the fundamental value, and this is a fundamental value in Medicaid that I certainly sign on to from a values perspective, is choice. So choice is, what do I want? Where do I want to go? and let me make those choices. My guess is that if your community has shared housing options, we may say, I can get out of shelter and into shared housing in 2 weeks. And I can get out of shared housing and into my own individual one unit in 6 months to a year. And then let that person make that choice. Every time I was also led a big initiative. We were moving people out of group homes and into supported housing in the Philadelphia mental health system. And what we found was that everybody, 2 or 1, myself included, did a terrible job at deciding, Mindy's ready to go to her own place and Kay's not, Mia needs more help, etc. And we were terrible. Okay, the one factor that we found that predicted who was successful in housing is the people who raised their hand and said, I want my own place. I want out of the group home. I want my own place. And that was the best predictor. So I would say give people choices, give people options. If a person can manage homelessness, they could probably manage whatever it is you're throwing at them, so again, choice, self-determination.
Thank you. And I will say part of choice is informed choices, right?
Yes.
Like, and we talk about this all the time. We all make informed choices about where we're going to live. When I moved to Baltimore, even though Baltimore is way cheaper than DC, I had a budget. Like, there's some wonderful, beautiful condos down on the water that I would personally, that would be my ideal living situation. I can't afford it, even though the Alliance pays well, right? Like, and having those realistic conversations with folks about what's your ideal housing? It might be for a family of 3, one where everybody has their own bedroom and we have 2,000 square feet. Okay, that's on our list of goals. How do we get there? That's how much that costs in this community. Here's how much your housing voucher covers. Here's how much your job pays, right? Like those, org code has that honest budget thing, right? Like, having those reality check conversations as well, because choice is choice, ideals are ideals, but we also have the context, the reality that we're living in. And that is true for if folks have mental illnesses or disabilities or money or no money, like we all are living that way. Did anyone else want to say anything on those issues?
So the only other thing I was going to say is that sometimes with the shared housing is that folks are living in shared housing already. If they're outside, they're usually sharing, some part of their outside space, and have often created their communities and, or even in, within the shelters or, wherever. So I think also when you do shared housing, it's also about choice. Like, are there folks that are part of your community that you'd like to stay with? So it's another way to talk about, it's shared housing, and you're in a shelter, it's shared housing without the rules, right? You just have to follow your lease. But if you want to come in at 2:00 in the morning, you can come in at 2:00 in the morning, So I think sometimes having some really robust conversations about that and what it means to be in your own space versus, in your own space where it's not going to rain on you if you're outside, and you can stay warm. But at the same time, look at what their relationships already are in their shared spaces that they are currently in before they move to housing.
Yeah, great. Thanks, you guys. Thanks. So Christy Schillenberg, the director of our capacity, the CAP team's all here except for Elliot, is in the chat now sharing some resources. There's the org code honest monthly budget that I mentioned. So we had some questions. This again, shared housing, but I think this is part of like when you're thinking about EHVs and services, we have to know like what can be funded by what and all of that. So this is related to this. Just a really quick comment on this, and then we'll move on to another part of the EHV conversation, which is some folks say that their grants don't allow for shared housing. Maybe there is some specific grant that says absolutely this person cannot be in a home with another person. I can't imagine what that is. I think there's some misconceptions about leasing and confusion about how to make shared housing work with things like rapid rehousing, where each individual client has to have her own lease. But you can do that in a shared housing situation. People do it all the time. My roommate and I in Arlington each had a lease with the property management company, right? Like, so I think there's just confusion about what allows shared housing. Any funding stream, you can do shared housing, even housing choice vouchers, right? Like people who are never homeless, people just who have housing choice vouchers share housing. Like, it's just a matter of leasing. Anyone want to check me on that? That's just my really brief, like, let's not assume we can't do shared housing with any of these funding streams, formally or informally. Most of them work unless there's some weird private funding that I don't know about that is just really anti-sharing housing with anybody.
So I think the one misconception about the regular vouchers, HCV vouchers, which are the
Right.
housing choice vouchers, Section 8, is that, the concern, well, like they can't have families living with them because they're going to use their Section 8. So,
Right.
so the technicality in that is that everyone listed that's living in the household must be on their lease, and they have to follow the standards of the Section 8, and all their income has to be reported. So that, however, it's often easier for the housing authority just to sort of say they can't be there, they've got to go, versus you can work with your local housing authority if they're open to it, and they can do this where they can actually get a 4-bedroom voucher if that meets their regulations. There's certain regs they have about the number of persons in a bedroom, and that's only for the Section 8 vouchers. That is not for rapid rehousing, and those resources. So I think I just want to make it clear that there may be language, or there may be folks saying, no, you can't be, quote, doubled up when you have a Section 8, but there's ways to do it legally, and that is reporting every single thing, right? And then somebody else said, shared housing is to fit into the FMR.
Right.
The fair market rent for rapid rehousing. But again, it's about the number of people in this size unit. And so I know that a lot of folks do. And so I don't know how much this is going to be with the EHVs, but we also know that a lot of times people do better when they are with someone. And one of the reasons people don't move into housing, if you're serving an individual household, is a concern about living alone and the loneliness that comes in. So I think, rather than talking as much about shared housing, because it's not as specific to this conversation, but also being aware that sometimes the best supportive services we can provide is another person to live with.
Yeah. Love it. Love it. Okay, we have 2 more minutes. Any last thoughts? Great conversation. I loved seeing from all of you in the chat kind of your ideas about what you're doing. Marcella, so much awesome information. I think I already see a policy project for CSH and the Alliance to work on together, which is mapping out that great chart that you had for each state. Because that is really helpful information for people to know and to see what's available for them. And it's one thing to go like, there are billions of dollars out there to do this, but like, what's actually in my state? What's involved for that? Any last thoughts?
Just wanted to kind of comment on, I think actually this was the very first question about what can you do tomorrow? And I just wanted to share that, while you guys are preparing to utilize these EHV vouchers, just remember that you're continuously having these engaging conversations with the folks that you are serving who are experiencing homelessness. So even if you are considering them for an EHV voucher, you're continuously working with them on, connecting them to resources that they need, preparing them to utilize the EHV voucher. You may not have certain information about what the PHA may require, but those are ongoing conversations that can aid in the housing conversations that you're already continuously having with folks that you're serving. So I just want to remind you all to, kind of continue that, getting to know folks, what their needs are. You can be having these conversations right now so that when you're ready to utilize those vouchers, you're prepared and you have a better understanding of how to best serve the folks that need your help the most.
Thanks so much, y'all. We are over time. Great comments. Just really quickly before we close out, everybody jump into the chat and see the helpful link that Deirdre shared, which is HUD's recent notice to PHAs, endorsing shared housing. Thanks, everyone. Like I said earlier, the webinar, go ahead, Kay.
Mindy, I just want to say Deidre shared that information with us, but I tried to pop it in. We will get that out. I don't think it went out to everyone, so we will get that out to everyone.
Okay.
That link just came to us about shared housing, a notice that went from HUD to the PHAs.
Okay, yeah, Deidre, that went to, yes, Donna, the chat will be available. We'll do all this in transcript. closing out. We're a minute over. There you go, Deidre. Thank you. Way to come in at the last minute. This has been a great team effort. Everyone check the chat, get Deidre's link. The recording, the slides, and the chat transcript will be available to all registrants. Great conversation. Stay tuned for the next in our federal resources series on using the COVID-19 funding to end homelessness. Have a great week, everybody.